Yes, so at ASH this year, we have a poster talking about the management of CRS and ICANS in our patients. So we looked at a cohort of 500 plus patients who had received CAR T-cell therapy, CD19 targeted CAR T-cell therapy, either axi-cell or tisagenlecel in the third plus line setting, and compared the outcomes according to CRS management. So we know now that, CRS can be intervened at grade 1 with both tocilizumab and or steroids, following cohort 4 and cohort 6 data from ZUMA-1, and many centers are applying that strategy. And that is different to, the previous, let's call it conventional management that we did before the publication of this data, where intervention for CRS was usually reserved for grade 2 or higher. So we compared the conventional management, applying that term to intervening at grade 2 or higher CRS, no intervention in terms of tocilizumab or steroids for grade 1 CRS, versus an earlier intervention, so that means applying tocilizumab and or steroids to grade 1 CRS. What we observed was a similar, CRS grade 3 or higher incidence. We did observe a significant reduction of CRS grade 2 or higher for patients with an earlier intervention approach. In terms of ICANS, interestingly, we didn't observe any differences, both in any grade ICANS, grade 2 or higher, grade 3 or higher ICANS. And I think what was more interesting about this abstract was really the data on cytopenias and infections, because we hypothesized that an earlier CRS management could perhaps lead to a decreased grade 2 or higher CRS incidence, but an increased risk of infections and or cytopenias. So when we looked at that, infections and cytopenias graded according to ICAT, so immune effector cell-associated hematotoxicity grading from EHA-EBMT, we observed that there was a higher incidence in those patients who had received that earlier intervention for CRS, that is to say at grade 1. And I think, this is definitely a retrospective analysis, but I think it's interesting data to try to tailor, the management we are doing today, currently, of our patients. I don't think every patient is the same. I think we do have to, assess, many factors when we are deciding and we're intervening at grade 1 or grade 2 or higher. But I definitely think that, in some centers, there can be a bit of over-intervention, applying many agents or many doses of that agent, for a single, grade 1 CRS after CAR T-cell therapy. So I think this is kind of an exploratory abstract looking at this hypothesis, and that will be presented as a poster on Saturday evening.